Good morning, everyone. We hope that you all are having a very pleasant morning. We welcome you all to another episode of the weekly Sunday webinar series brought to you by the Society for Health Research and Innovation. Before moving on to the lecture, let me walk you through some of the housekeeping rules again. The webinar link will be available from 9 a.m. to 9:50 a.m. for you all to join in, and after that, no late attendees will be entertained. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points. And these CPD points are strictly adhered to the NCCPD guidelines. We keep these rules to improve and maintain the standards of the sessions conducted by the Society for Health Research and Innovation. And we thank you in advance for your compliance and strict adherence to these rules and regulations. There will be a question time at the end of the webinar. If you have any questions, you can type it in the chat function. And if you have any specific questions, you can email it to office313@gmail.com or join with our WhatsApp group. Moving on to the lecture, today we have another interesting topic, Sarcopaenia. And our speaker for today is Dr. F.H.D. Shehan Silva. He's a senior lecturer in the medicine department in the Faculty of Medical Sciences, University of Sri Jayawardenepura, and a consultant general physician in the Colombo South Teaching Hospital. Over to you, sir.
Good morning, ladies and gentlemen. It's a pleasure to be back delivering a lecture for free. Thank you for inviting me. Yes, give me a moment till I share my screen. I hope you can see my screen. So today, the topic that was put out on the poster, the flyer, was on sarcopenia, but I thought it is pertinent to speak on frailty as well. So the slide may have the title as frailty and sarcopenia, but we will definitely talk about sarcopenia in more detail. But it's important that we talk about frailty as well, that is also associated with sarcopenia. So there's a clear understanding of what this talk is about. So this topic, sarcopenia and frailty, is in the lines of geriatrics, elderly care medicine, very important area that is established in Sri Lanka as well as which needs to be improved. As you know, our population is advancing to an older population. The number of older adults are increasing, the birth rate is reducing. So the burden, the number of people who are older than 60 years of age will be greater. And added to that, there is also an outward migration of individuals to greener pastures. And so there will be a deficit of the labor force and the younger crowd. So there will be more older people. And as it's projected, you know that by 2040, 1 out of 4 adults will be older adults. So with that preamble, we start off with this quotation by Shakespeare, his famous poem, 7 Ages of Men, the last stage. It says, all men and women are merely players, they have their exits and entrances. The last scene of all is strange, eventful history, second childishness, a mere oblivion, a mere time of, forgetfulness, dementia. Sans teeth, sans eyes, sans taste, sans everything. There is deterioration and loss of teeth, eyes, taste, and everything. Is that so? So start off with this patient. The photo is, of course, a hypothetical photo, but this patient is the case history is a real case history. We have a 78-year-old man who's a retired clerk, comes with worsening shortness of breath and fatigue over 6 months duration. Currently, he's having breathlessness with minimal exertion, and the exercise tolerance is now limited to less than 20 meters. Quite dependent. He has had many falls, one per each fortnight. There's no consciousness change with falls. Now using a frame, a walker. He feels tired. He says that he's feeling tired and he sleeps most of the day. Remind yourself about your loved ones, your older adults, your mothers, fathers, your aunts, etc., uncles, etc. They feel tired, they sleep a lot the whole day and reluctant to go outside. They are housebound, becoming forgetful more than 6 months, and somebody has started on donepezil and memantine, thinking that this is Alzheimer's disease. But there's poor response. So if you take the palm of the patient with the behet, and you see that there's a number of medication, aspirin, simvastatin, furosemide, metformin, citalopram for depression, iron sulfate, allopurinol for the bowels, loperamide, omeprazole. And added to that, we see people sending with love from abroad. You see people sending big bottles, fish oil, ginseng, multivitamin, vitamin D. These are the things that people bring to the clinic or to the ward and say, doctor, is this okay to take? This is what my daughter sends from abroad. So the patient has a BMI is 18, low weight, pale, having edema. There's but there are no nutritional stigmata. The pulse rate is, give me a moment. Sorry, the pulse rate is 68, the blood pressure is 110/90, when there's a postural drop, there's orthostatic hypotension. There's a ejection systolic murmur, which is heard at the aortic area, which is radiating to the carotids. In older adults, we see this. It may be aortic stenosis or it may be aortic sclerosis. Respiratory system has bilateral crepitation, the abdomen is normal, but there's gross wastage of the calf, thigh, arms, and muscle, and patient is unstable. Postural sway is there. The grip strength is not there. And you do MMSC, you see that patient is having a MMSC of 20 out of 30, or a MOCA or Montreal Cognitive Assessment, which is 80 out of 30, again suggestive of moderate dementia. Then he has problems. These are the problems that you would tend to identify if you are working in a medical ward or even in a primary care setting. This patient having acute pulmonary edema in the background of severe aortic stenosis. There's postural hypotension and dementia. But what about frailty and sarcopenia? We tend to take it for granted that we do not think about this at all. So what about frailty and sarcopenia? So before that, I take this diagram. So all of us have a chronological age and biological age. The chronological age is what our birth certificate bears. Or medical legally, administrative point of view, the birth certificate will tell, okay, how old you are, whether you're five hours old or 90 years old, 40 years old, whatever. But then there is also a biological age, how we manifest ourselves to the world. We can conceal it, we can accelerate it. We see that there are actors, even politicians, who conceal the biological age by putting makeup, Botox, whatever. But then chronological age is a static thing, as in nobody can conceal that. But the biological age can be concealed. Otherwise, what would happen is, compared to a person who's having a particular chronological age, the biological age can advance. Although you're maybe 40 years of age, you have so many diseases and you're very weak, your biological age may be greater. The other reverse also can happen, just like the man who has a walking stick, who shows much independence. The chronological age can be greater, but in fact, he is young at heart, young at body. Biological age is less than the chronological age. If there are three individuals that I want you to see, you have the late Queen Elizabeth II, who died at 97 years of age. Till then, few hours before her, till the time that he died, she was doing her administrative duties, her constitutional duties, governed 15 countries, and her mental faculties were good compared to her frailty. On the middle, you have Stephen Hawkins, who died at the age of, I think, about 67, roughly. But from the time that he was 23 years of age, he died. He had motor neuron disease, and he was pretty much bedridden. And then he got out of it, and he was mobilizing on a custom made wheelchair with communication devices, etc. And he brought into the world his theories, greatest scientists in the modern era. On your extreme right, you see an individual. If you can guess his age, how much do you think? You see that he's old, he's bald, he has wrinkled skin, he is visually impaired, he's cachectic. Can you believe that he is 13 years of age? So this is a state called progeria. And I have not seen it in Sri Lanka. I don't think there are any case reports in Sri Lanka yet. But you see there's accelerated aging, which is not related to the chronological age. So you see the disparity between chronological age and biological age. So what happens with your birth until your death? So we come to a point of zenith or our peak by the age of 2030, around that time where our functional abilities come to the peak. And thereafter, it gradually reduces, it wastes away. So there is involvement of the environment, various diseases, maybe communication, non-communicable diseases like diabetes, hypertension, etc., coming into the picture. Injuries, occupational or otherwise, which change the trajectory, the projection of this curve. And you see that the curve ultimately gets deviated towards towards the x-axis more with these factors. And thereafter, it reaches the dependency threshold, and we have become impacted in our lifestyles, and ultimately there is the culmination of death. But our goal should be to change this curvature, the projection towards the one win broken lines by changing of lifestyle and also correction of various communicable diseases and factors and etc., reversible factors. So the WHO has put out this concept of ICOPE. So some people would have done this course where you look at a patient in these 5 realms: the sensory realm, as in your senses, the hearing, the vision, the proprioception, your vitality on how you have strength in your body, your muscles, etc., mobility, your joints, your cognition, your thought, and psychological, your emotions. So these all 5 together is called intrinsic capacity. What we as each individual, irrespective of our environment, is having. We have our sensations, we have our mobility, we have our strength in vitality, we have cognitive levels, and we have psychological well-being, all of these together. So with the intrinsic factor, you also come across a thing called functional ability, where there is combination and interaction of intrinsic capacity with the environment that you have, the various interactions that you have with the environment, and you see it's a wider circle. So functional ability is your intrinsic capacity as in what you have in your body interacting with the environment, and you see it's a wider circle. So our goal is to change this trajectory. As I said, the intrinsic capacity, as you see, is the brown line. The functional ability is the blue line. And as you see that as you age, there is a large gap between the functional ability and the intrinsic capacity. So with our lifestyle changes as well as our interventions on life, as in medical conditions and pharmaceutical conditions, we push this line towards the functionability, and thereby we further push up the curvature of life. So having said that, what is frailty? Frailty is a distinct health state which is related to aging. where multiple body systems gradually lose their inbuilt reserves, the ones that we mentioned about the intrinsic capacity. As we age, we will have wastage as well as gradual decline of the body systems and their reserves. So take a good example. You have one individual who, let's say you get a urine infection. Let's say you are 40 years of age, you develop a urine tract infection, just like what you see in the green line. You have a mild infection, and then immediately you will feel weak, you can't do your work, you'll have fever, loss of appetite, you'll be a little bit, put off. And then you take the medication, the antibiotics, whatever treatment that you have, and then you bounce back to the same line. You see that the green line is a continuation at the same line, but it improves with a shorter period. But an older adult, let's say somebody who is towards 70, maybe the other way around as well, but usually an older adult, let's say somebody who's 70, who has diabetes, pressure, etc., and maybe having mobility issues. You see that there's a disparity between the green line and the brown line. Brown line is quite lower than the green line. So the functional ability on an older person is lower than the functionality of a younger person. And the same factor comes into play. Then you see that that person plummets to dependency, greater level of dependency. And you give the same treatment, maybe you give with the aggressive treatment, but still for all, it takes a longer time than the man in green. And what do you see? Even if he recovers, you see that the functional ability has dropped. This is what happens with his frailty. It's a gradual process where multiple body systems lose their inbuilt reserves. So outcomes of frailty includes independency going into dependency. The ability to move is leading into immobility. Patients will have postural stability, right? Leading into falls and instability. You see somebody who gets a urinary tract infection, sometimes they may not have dysuria. Older people, they may not have dysuria, but they will have vague system, poor appetite, and suddenly they may lose their legs and they will fall on the ground, and they have a fracture of the hip. They come to the orthopedic ward, and then they are treated. And then they are treated for the orthopedic problem, the fracture, but patient doesn't recover. And then incidentally, they call the physician and say, okay, can you see what's going on? And lo and behold, they have a urine infection going on, which patient didn't have fever, patient didn't have dysuria, patient didn't have lower tummy pain, but patient came with a fall because of the postural instability. Other outcome of frailty is going from lucidity into delirium. Lucidness is how conscious you are, how well you are interacting with the environment, and how bright you are. Okay. So frailty can be looked in two models, where you look at the phenotype of the appearance, or you can calculate the amount of deficits or problems that you have. We'll talk of this now. Sorry. So phenotype model is also called the Fried phenotype, which was described by Fried, a geriatrician, who said that frailty has 5 aspects. What are these 5 aspects? Very important. Is there unintentional weight loss? Not dieting, not starving, not having a medical condition which is obvious. There's unintentional weight loss of more than 5% per year. What in UK they say is 10 pounds over 12 months, or even 5 kilos over 3 months duration, right? But the important thing is the unintentional. They are not fasting, etc. Decrease walking speed. They are not able to walk fast. They are not able to walk in the average speed. I will teach you something where how you can look at this in your clinic and your practice. There's a test called a tug test, or a timed up and go test, where you can see how long do they take to walk, decrease walking speed. Their energy expenditure is low. right? They will have low physical activity. It's beyond the discussion today, but there is a thing called pace or physical activity scale of exercise, which is there, where you can grade the amount of exercise or even the activity like you do, like even cutting a tree or digging a hole in the garden. With that, how much of energy that is there? Something, it's called pace. It's validated for Sri Lanka. You can use it. So you can look at how much of energy they have in expense. Self-reported exhaustion, where you can use the CES depression score, which we will tell about the fatigue level. Fatigue. You can ask, do you feel that uh, you are exhausted or තෙහෙට්ටුව දැනෙනවද ඔයාට මහන්සිද like. And the other way is the other aspect is the weakness, the grip strength. You can just ask them to grip your two fingers and see what kind of the grip they are having. If you can quantify, you can use the handheld dynamometer and check on their grip strength, which there are cutoffs for various powers. But you need not do that. But in the clinic, you can just simply ask them to, grasp your two fingers and grasp your two fingers like this and see whether they are able to make a good grip. So 5 things in the fried phenotype, very easy. Do you have a loss of weight? Then you can assess the walking speed, the slowness. You can assess the physical activity, how much of activity they are doing, whether they feel tired, and whether they have weakness. So if you have 3 or more of these characteristics, you're considered as a frail individual. There's also a thing called cumulative deficit model, where you can also add on all the conditions that there are in a list. It's by a person called Rockwood. There is a scale. There you have the electronic, as in your phones, etc. You can do this, where you add on all the conditions that the patient is having, and let's say you have a score of 4 today. In 1 year's time or 6 months' time, you look at the score and you see whether new things have come out. 4 has become 8 in 6 months. That means patient is moving towards frailty. So that is called the frailty index. I won't discuss this too much. Or in the clinic, you can also ask about a more, prompt way. It's called the Prisma 7 questionnaire. There are 7 questions. Are you older than 85? Are you a male? Do you have limitations in your activity? Do you need someone to help you on a regular basis? Do you require you to stay at home? In case of need, can you count on somebody? And do you regularly use a stick or a walking stick or a chair? So if the score is more than 3, it is considered a person with frailty. So you can read up about this, the Prisma 7. It is validated Sri Lanka. You can use this in evaluating frailty. This is a picture that I like very much. I want you to take a moment, few seconds, and ponder what what icon are you falling into today? Are you 3? Are you 2? I may be 3 to 2, 3 to 2 roughly. I hope I can be 1, but what are you? Think about your mother, your father, your grandparents. Think about anybody who you know really well who is not doing well. What level is that person at? This is something very easy, pictorial, that can be done. Recently, we validated this to Sri Lanka. We're just awaiting the publication happening, where even a consultant or even a house officer would be able to look at frailty and tell, okay, this is, and it has good concordance. So I spoke of the timed up and go test or the tug test. This is what I was meaning. It's a very simple test. In your clinic or in your practice, you tell get the patient to sit on a chair with an armchair, and you tell, look here, please listen to my instructions, perform the task, and I am going to count how long you are taking to do this. So the person who's seated has to walk a distance of 10 feet or 3 meters, turn around, come back and sit down. You give clear instructions. You're seated now. I want you to walk from here up to that particular point, which is 3 meters. You know how that it is 3 meters or 10 feet. Turn around, come back and sit down. And you calculate how long they take to walk. So roughly, if they take more than 8 or 10 seconds, there are various cutoffs for various conditions, whether they have joint problems or mobility problems or even using a prosthesis. But roughly about 10, more than 10 seconds, if they take to do this, they are considered frail. Now we come to the crux of the matter, the talk. It's on sarcopenia. So what is sarcopenia? Have you heard of this? You must have heard of the word osteopenia. So sarcopenia is similar to osteopenia, but here we are talking of the flesh. Sarx, as you know, is the Latin word for flesh, and penia is the loss. And there is loss of mass muscle. So in fact, this was put out by a person called Rosenberg in late 1980s. She described this that with age there is loss of muscles. There's progressive loss of muscles. Number one is the muscle mass, the number of kilos that you have. The mass, the muscle, not the fat. The strength of the muscle, how strong you are. And with that strength, what kind of physical performance that person is able to do. So three things. It's not only the muscle bulk, it's also the strength and the performance. A person who has a low muscle mass may have a greater strength and have good endurance. It may be the other way around. Person who has greater muscle mass pumped up with creatine and everything, etc. But the patient's strength may be there, but the performance may be not optimal. So it's a very vague or very paradoxical area where you have three elements: the mass, strength, and physical performance. And you see on this image on your right, you see two individuals who are maybe the same age or so. You see that you have a person who is, let's say, 60 kilos on your left, and then somebody who is 90 kilos. You think, this person is having more weight, he should be also having muscles. But in fact, he has low muscle mass. She has low muscle mass and she has more fat. In fact, the thinner individual has more muscles but less fat. Can you see the disparity? Can you appreciate that? That is what is meant by sarcopenia. Sarcopenia is actually something that people may get fooled with. You may think, okay, you're prosperous, luscious, lavish, etc. But then underneath that skin, it's all fat, low muscles. Right? So this is what we are talking. So nearly 25% of individuals who are 65 years or above, that is older adults, nearly 1/4 will have sarcopenia. And when people are over the age of 80 years, they at least about 60% or more than 50% are affected with sarcopenia. So what? So sarcopenia is associated with disability, poor quality of life, and even lead to death. So you see some curves here. You see somebody who in the most left, you see with age, men and women. Men are greater than women with regards to muscle mass, obviously because of the testosterone effect. You see as age goes on, the muscle mass goes down. As age goes on, the muscle mass goes down. You see the rate. If you take the age with regards to the strength of the muscles, so you see that as you age, the muscle strength also goes down, right? If you take two individuals who are of the same sex, but one person is trained or having good physique, or not only physique, good endurance, and the other person is just a couch potato, you see that as you age, how bad the strength goes down in a person who is untrained, but the person who is trained has not so much of a big change. Maybe with after 70, 80, there is a drop, but that drop is not so substantial compared to the one who is untrained. So how do you detect sarcopenia? So there is a this is a screening test. This is called the SARC-F, which can be used to detect, where you look at 5 things: the strength, how much you ask certain questions. You have to look at the strength, assistance in walking, rising from a chair, chair rising, or climbing stairs or falls. You ask certain questions. How much difficulty do you have in lifting or carrying a 10-pound weight? That's about 5 kilos or so, roughly about 5 kilos. So whether they have difficulty, whether they have a lot of difficulty, whether they need assistance, whether they use various devices, whether they are able to rise from a chair, whether they are able to climb a flight of 10 stairs, falls. So somebody who has a score greater than 4 is predictive of sarcopenia. Predictive of sarcopenia, not that you're diagnosing sarcopenia. You are able to tell just by asking, looking at the strength, looking at the need of assistance in walking, whether it be a person physically helping or using a hermetia, whether they are able to rise from a chair, difficulty or there, climbing a flight of stairs, or whether they have increased risk of falls. If somebody has more than 4, it is a prediction of sarcopenia and the poor outcomes. So these can be done if you have these facilities, but these are also in research levels. DEXA scanners, I know that we do it for bone mineral density, but you can also do DEXA scanning at clinic level for sarcopenia. Very expensive for you to do it at your onset, because the initial cost is greater, and you might not have so many people who will be coming for a DEXA scan like that. But you can easily do a thing called bioelectrical impedance analysis, where it's like a weighing scale, and there is also a interface where one has to grip. I bought recently one for roughly about 50,000 or so, right? And I'm using that. It's quite useful. You can use it in the clinic for a person who's able to stand. DEXA scanner, you need not stand. You have to, anybody who is not able to stand even you can do. But the bioelectrical impedance analyzer, one needs to be able to stand. That's one disadvantage. The other disadvantage in bioelectrical impedance analysis is that the instrument is only validated for people less than 8 years of age. So somebody who is an older adult or above 80, it's not possible for you to do it, because you can do it, but the value may be giving a false result because you can't validate. There are no scores that are validated. No? So that is muscle mass. This you can do at your clinic easily on the wards. You can look at the calf circumference and the mid-arm circumference. Depending on the age and sex, there are various cutoffs which you can Google and find out. You have to use for South Asian individuals. This is very useful. Muscle strength, again, something easily that you can do. You can use a gadget called the handheld dynamometer. Again, not so expensive, maybe about 10,000, or you can get a good one for about 10,000 rupees. But there are Chinese ones also. I don't know about the validity of those, but for about even 2,000 rupees, you should be able to get it. And the other thing that you can use a surrogate marker, not that it is directly associated with muscles, but you can use it as a surrogate marker. You can check the peak expiratory flow rate, provided that they don't have asthma and COPD. These are tests that you can do. Then, of course, you have to use the gait speed. Again, the speed at one particular person should be walking Remember, you have to have an acceleration zone and a deceleration zone. Unlike you and I, who may be robust, older adult will take time to catch up a particular level of catch and then start walking. So you have to have an acceleration zone, which is about 2 meters. You give it space, maybe about 5 meters, and then you have a deceleration zone where you let him slow down and come to a standstill. So in that walking period, that white color area, you can, from the start of it to the end of it, you can take how long person is taking to walk, and you can get the gait speed. Tug test I have already spoken of, so I don't going to talk of this. There's also a thing, or these are all diagnostic for purpose. You can also do the thing called the short physical battery performance, where you can do the balance test and the gait speed test as well, where you see whether they are able to stand and whether they are able to walk, etc., and come to a consensus about really whether they are having physical endurance problems. Right? So with that, how do you incorporate it? So you detect or you have a suspicion that somebody has sarcopenia by looking at the SARC-F. And if it is positive, you have to assess the muscle strength by grip strength or the chair stand stress. Then you confirm it by doing a DEXA scan or a biometric electrical analyzer, impedance analyzer. The gold standard, of course, is an MRI, which you can't do in our setting, but at least a DEXA scan or bioimpedance analyzer you should be able to do. And for confirmed sarcopenia, you have to look at the physical performance by gait speed, the battery performance, the tug speed test, and the 400-meter walk. So you see that there are four orange squares. You have a clinical suspicion that somebody is having sarcopenia, and then you look at the strength of the person. One component of sarcopenia is the strength. Then you look at the quality or the quantity by using the DEXA scan or the bioimpedance analyzer. And that is the muscle quality, the strength, the mass. Then you have the physical performance. Those three things that I told about muscles. So as one person ages, there is a process called inflammaging, where there are inflammatory markers come into play and tips off the balance. There are cytokines coming in, there's insulin resistance occurring, cardiovascular deaths. All of these is because of inflammation-related, aging-related inflammation. So there is also a condition called cachexia. Cachexia is what you see in people who have chronic debilitating illnesses like tuberculosis or a malignancy, where the muscle protein synthesis also decreases, like in sarcopenia, but there is more degradation. There is breaking down of muscles in cachexia. And you see that the muscle strength is decreased in both sarcopenia and cachexia, but the fat mass is increased in sarcopenia. In cachectic patient, there is reduction or no change of the fat, whereas in sarcopenia, you see that persons have reduced fat mass. And there is in greater degree of inflammation and insulin resistance. Remember that, as I mentioned before, people who are very plump and maybe prosperous looking, you may think that they are physically fit, or when they're not fit, they may be having adequate muscle. In fact, they may be having sarcopenic obesity, where there is more fat compared to muscles, and the tires are actually a result of increased fat being deposited instead of muscles. So how do you deal with it? You have to go with diet control, weight loss, and regular exercise, which we'll talk of in a little while. We'll go on to this. So you need to find out about the secondary causes of sarcopenia. What are the other conditions that can worsen sarcopenia? Is it because of activity related? First people are not active, they are not physically mobile, they are very, very like couch potatoes, sedentary lifestyle. Is it because of diseases? Is it because of advanced organ failure like heart failure, liver failure, renal failure? Is it because of malignancy or endocrine disease? Or is it because of nutrition related, inadequate diet, malabsorption, etc.? Added to that, is it because of hospitalization? When we get a patient to the hospital and they are there for a longer period, every day once a patient is bedbound, not mobilizing, no physical therapy, etc., there is loss of muscles, 1% muscle loss daily occurring in a person who is bedbound with an acute or critical illness. So it's essential that even critically ill patients or even acutely ill patients, there is some amount of physical activity and therapy going on. So how do you manage this condition? You have exercise, you have nutrition, pharmacological agents, and psychological well-being. Remember that there are two types of exercise. You have the resistance exercise and the aerobic exercise. Aerobic exercise is what we like because we want people to, go from one place to another, whether it is walking, swimming, cycling. You know that it increases the number of mitochondria in endurance or aerobic activity. Resistance training or strength training is what is like weightlifting or stretching exercises, where there is increase of functioning mitochondria occurring. So the quality of the muscle is improved with resistance exercise. There is muscle mass, quality, and neuronal adaptation. Important aspect is there are people who come and tell, okay, doctor, I am very active. I do walking every day 15 minutes. But the next question is just like that, good, keep up the good work. Are you also doing some resistance or strength training? Resistance bands, weightlifting, etc. Because with resistance exercise only, the strength is gained, the muscle mass as well as the quality and the neuronal adaptation occurs. It's essential that this is targeted. So what do you mean by resistance exercise? So you can tell them to do every other day or every third day, because you have to give time between the exercise for the person to recover from the little bit of trauma, micro trauma that happens, which is important to help to repair and rebuild. That bit of muscle trauma that occurs with exercise is the stimulus for muscle to rebuild. And you tell them to do repetitions and sets. Repetition is one complete movement of an exercise. You tell them, let's say you tell the patient to do a flexing, that one complete movement is a repetition. And a set is you tell them to do at one time, you do 20 of that with a weight. That's called a set or a group of repetition. For a young new exerciser or an older adult, you start with one set. One time you tell them to do, you do start with bending of the joint 10 to 15 repetitions initially. Initially start with lighter weight, but later on increase the weight. Gradual increment. So you start off with one set and then you can go up to even 20 sets, but few repetitions where higher strength is needed. It's essential that they take 2 to 3 minutes between the sets. Between the sets, the groups of repetition, they take set. And it's essential that you tell them when they are doing that, you tell them to do it over 3 seconds for the effort, keep it for 1 minute, 1 second, and then extend for 3 seconds. 3 seconds to bend like that, keep for 1 second to hold, and 3 seconds to release it. 3-1-3 rule. So all the muscle groups should be used. You can use these dumbbells. If dumbbells are not there, you can even tell the person to use a can like that, graduated cans or even sandbags. Very important. Otherwise, you can also take these things which are not so expensive, these resistance bands, maybe about 5,000 to 10,000 rupees, with graduated weight bands, which you can use. Important that you start low and go slow, be opportunistic and innovative. Nutrition is essential. It's noted that muscle protein synthesis rate is reduced 30% in older adults, and in older adults, it should exceed more than 0.8 grams per kilogram per day. And it is suggested that in a sarcopenic or a person who is cachectic, at least 1 to 1.2 grams per kilogram per body weight per day is given. It's very noteworthy that certain amino acids like leucine have an anabolic effect. Leucine is an essential anabolic amino acid which has an anabolic effect. It stimulates protein synthesis. And there is also a metabolite called HMB or hydroxymethyl butyrate, which is a metabolite of leucine, which has also shown some promising results. So what are the substances that have leucine? This is where the whey protein concentrate comes. That's why bodybuilders take whey protein. But you don't have to tell your older adult to take whey protein. Expensive, and you have to be mindful of the renal load as well. But then other things like soya beans, fish, chicken, an egg, your paripu lentils, chickpeas, corn, cow milk, all those things have, but you see how much it is less. But at least if you substitute by chickpeas or chicken or fish or soya beans, cowpea, dabala, all those things, you can improve in nutrition. Micronutrients are also important, substituting with iron, folate, vitamin B12, B16, 12. Education of how to prepare food, be innovative in cooking is important. Some areas that are developing are things like about omega-3 fatty acids. A lot of talks are there about the effects of omega-3, that it reduces inflammation. Prebiotics, but they are galore in market. Tea, green tea, olive oil, all of these are still, you have to take with a pinch of salt, but they are things that are coming. So there is a synergistic effect with exercise and diet, long-term effects of combined exercise training and higher protein was proven certain. But now there is a trial, actually this slide should be updated. There is a trial called the SPRINT trial, which showed, which is a European trial on sarcopenia and physical activity, frailty. It showed that it has a synergistic effect. Pharmacological agents, there is in grants, there are reviews that have been done about certain medications, but these are the drugs that are there: testosterone, dihydroepiandrosterone, estrogen, growth hormone, angiotensin converting enzyme inhibitors like ACE inhibitors like enalapril, etc., creatinine, cytokine inhibitors, myostatin, activin receptors. So you have a lot there. But all of these, you see that most of them are hormones, very important for physiological growth, but all of them, they come with a price to pay. Lot of side effects. Testosterone, estrogen, growth hormone, when you abuse them, what kind of side effects they have. So should not be generalized. It's not, and also it's not there in guidelines yet, because these are still thoughts of being incorporated into practice. There are other agents also coming in, like selective androgen receptor modulators, skeletal troponin activators, and ghrelin agonists, which deal with the appetite pathway, right? Things that will come in the future. What about a pill for exercise? Can we take a pill for exercise without doing a physical exercise at all? It's also been spoken of AMP-related protein kinase, PPAR, beta delta agonists. But very important is there are some reports saying that metformin has some AMPK activation. It prolongs aging, delay aging. Vitamin D also can be used with vitamin. You know that vitamin D is associated with deficit. It is deficient. It is associated with falls and hip fractures, etc. So vitamin D has an improvement with regards to increased muscle strength, and vitamin D deficiency has shown that there is atrophy and weakness of the muscles. So is there some role in optimizing vitamin D levels? Omega-3 we discussed. You need to assess the patient with regards to decline in function and strength. It's not only a one-day story. You have to look at the patient every 3 months or 6 months or, a regular. Look at the activities of daily living and instrumental activities of daily living, false risks, gait transference and balance, and the presence of multimorbidity and polypharmacy. Therapy needs to be implemented. It should be customized with a plan. You can't ask a lady who is in a village, 60-year-old, 80-year-old lady who is in a far-off village to wear a track bottom and then go on a walk on a jogging pathway in Nugegoda or Colombo near the Independence Square. So you have to be innovative and you have to adjust your regime. What can that Archie do in that village? How can he do resistance exercise without doing resistance bench? He can get some Valicote sandbags of graduated weights, 1 kilogram, 2 kilograms, 5 kilograms, and do those exercises privately. They don't want to go to them. Encourage mobility. Make sure that posture and appropriate weight bearing is done and advise on good nutrition. So I come back to that curve again. Finally, we discuss about this curve where you see that there is a age-related decrease of muscle mass, strength, and the physical performance. And you see that there is a big disparity between the curve that which ought to go and which is going. So it's your job to reduce this burden as well as reduce this disparity. So procrastination is the thief of time, or putting something late towards a later time is the thief of time. So the best time to plant a tree was 20 years ago. That's what the Chinese say. The second best time is now. Okay, thank you very much. There are questions, I would like to entertain them.
So there's one question.
Yeah.
Is there a place in measuring muscle mass to assess fitness for chemotherapy?
For chemotherapy,
Yes, sir.
actually, that's a good question. There is a thing called ECOG. I can't remember the long name. It's related to the performance scale. That's something that can be done. I don't know whether at Maharagama or in the oncology units they do that. But it's a good way to see whether that it's objective way. Definitely, it can be used. It should provide some insight. Thank you for raising that up. That's actually a good area to do a study. Yes, definitely. I would agree. Yeah.
There's another question. Is sarcopenia reversible?
Sarcopenia is reversible, but it may not be fully correctable, right? So it's like osteoporosis. Osteoporosis is so actually sarcopenia is actually the prototype of the condition for muscles that happens with osteoporosis. So there's no word called sarcoporosis, but then what happens in osteoporosis is you give the calcium, the vitamin D, the proteins, and then you give the bisphosphonates, and you see sometime later whether that the FRAX score as well as the T score, whether it improves. Yes, it improves, but it may not be correctable. It may be reversed, but it may not be fully correctable. Yes.
Another question. Can sarcopenia influence perioperative and postoperative outcomes?
Definitely. So just like the question on chemotherapy, sarcopenia will give one person the vitality. This is a feature of vitality. So the person who has low muscle mass will definitely be weak in recovery. That's the same concepts that we use when we say in the ICU, especially we say somebody who has low physical reserves. Actually, other than the heart, the lungs, one also has to look at the muscles as well, because the muscles are the batteries of proteins, because from the muscles only the proteins are released when somebody is in an acute phase. So if one has low muscle mass and low muscle strength, that person will not have enough capacity to recover from after an insult. May it be a surgery, may it be a critical illness like a myocardial infarction or even a cardiac arrest. So definitely, yes, muscle mass as well as the strength, sarcopenia is influencing, yes.
One more question. In the presence of joint diseases, how to optimize exercises in older adults?
So it depends on what joints they are and how well you control them. So you have to have a good control medically as well as in a rheumatological point of view, good pain control, as well as you might have to use certain aids like maybe slings and supports, knee guards, etc., so that the laxity doesn't go. Definitely, you can't ask somebody who has a deformed, let's say somebody has a deformed shoulder, you can ask the person to do weightlifting where you do a clean slide, where you have to tell them to lift a huge 20 kilo weight or 40 kilo weight above their head, like weightlifting. So the range has to come into being, the power has to come into being. So you need the help of two individuals. There are sports and exercise physicians now, at least in the major hospitals, that breed of consultants and specialists are coming in. Then also there are diploma holders of sports medicine. So get hold of those people and have a multidisciplinary, interdisciplinary collaboration. The other set of individuals who are very useful is, please step out of your MBBS glasses, get your physiotherapy colleagues and the occupational therapists involved in the management of your patients. They can really help, because we do not have the skill or the time. My time is also there to uh, address those physical aspects, the physical therapy aspects in improving a person's endurance. So please get hold of those two individuals, the sports and exercise physicians and the diploma holders, as well as your physical therapists and occupational therapists.
There's one more question. When to suspect sarcopenia in young patients?
Okay, yeah, sarcopenia in young people, you have to think again, somebody who has chronic illnesses. Let's say you have a person who has a chronic, maybe even tuberculosis, right? Or somebody, even a drug addict who comes with a wasted cachectic appearance. Somebody who you feel that is wasting away, poor dietary regimes, psychiatric patients, anybody who catches your eyes, right? Particularly, remember to, if you feel that they are wasted away and they are having exhaustion, ask those 5 things. Look at the rib strength. You ask whether they feel tired, whether they have lost weight, whether they have lost walking speed, etc. And definitely target. Remember, aging is not just above 60 years of age. As I told you, progeria is there. Spoke of this guy, uh, Stephen Hawking. I spoke of the Queen. So you see that it's a vast array, chronological age, biological age. So you don't have to apply these principles of geriatrics only above 60 years of age. Even for a 40-year-old person, it may be there. Yes.
Thank you very much, sir. That's all for the question.
Thank you.
We thank you sincerely, Dr. Shehan Silva, for this excellent, timely lecture and your precious time.
Thank you. Thank you very much. If
There's a
anybody
link in.
wants this presentation, they can email me. I'll put it in the chat box.
Thank you very much, sir. There has been request for the lecture
Yeah,
notes.
I sent it on the chat box. D Shehan S at sjp.ac.lk.
All right, sir. Thank you very much.
Thank you.
There's a link in the chat box for your certificate. Kindly give your feedback and answer the post-assessment questions. You will be receiving your e-certificate for participation within today or within this week. If there are any concerns, please contact the WhatsApp group of the Society for Health Research and Innovation. We thank you all for your participation and hope you join us next week, next Sunday as well. Thank you very much.